Welcome back to the physiology of the gastrointestinal tract. Uh, Yesterday I talked about the second part of special physiology, which is gastrointestinal secretions. The first part was gastrointestinal motility. All of this followed the first part of physiology of the gastrointestinal tract, which was general physiology. And I talked about the structure of the gut and the control systems of the gut. Yesterday we started talking about two types of secretions. Secretions that are coming from the epithelial cells and secretions that came from the salivary glands. We also started talking about secretions coming from the stomach. We stopped there. Now the secretions that are coming from the epithelial cells were protein and electrolyte, mucus, and special molecule, and we talked about different functions. For example, mucus lubricates and protects. Water forms a good reaction medium, liquefies and dissolves the food that we consume, and it also produces the hydrogen ion and the bicarbonate, which are very important to produce acid and also to balance the acidity. We then went to the secretions of the salivary glands, and we talked about them as very important from a standpoint that are they're important for digestion, for example, lubrication and protection, and they can be serous or mixed. We've talked about their components being organic and inorganic. The organic consists of digestive enzymes, mucus, lysozymes, and calcrines, whereas the inorganic salivary secretions consisted of ions such as the chloride, the sodium ion, potassium, bicarbs. Then we moved to talk about the gastric secretions, and we said that there are four gastric secretions: the hydrochloric acid, the pepsinogen, the mucus, and the intrinsic factor. Also, we mentioned how does hydrochloric acid function to activate pepsinogen into pepsin, and so on and so forth, and how is it a bacteriostatic rather than a bactericidal, and how the mucus can be either lubricant or a barrier in cases of to protect against gastric ulcers. And we talked about the intrinsic factor to be a binding to vitamin B12, so we have to provide B12 to those who does not have the intrinsic factor. Now in this lecture, what I will do is I will continue on the topic of the gastric acid secretions, and we will mention how is the gastric acid secretion being controlled. What controls gastric acid secretion? How does the control of gastric acid secretion take place? We have three phases that will control or will participate in the secretions of gastric acid. Three phases. All of them happen during the digestive state. The digestive state or phase, which means that the person or the animal is actively involved in eating as we speak, not the interdigestive state, but the digestive. And these phases that control gastric acid secretion are cephalic phase, so it's something that's controlled centrally from the brain, gastric phase from the stomach, and intestinal phase. We'll talk about each one of them separately. Now, the first phase that controls gastric acid secretion is the cephalic phase, meaning that central control of gastric acid secretion. This accounts for about 30% of the gastric acid produced. So 30% of gastric acid is basically under the control of the central nervous system and mainly the vagus nerve. And we remember how we can reduce this amount by doing a selective branch vagotomy. We've talked about when we treated gastric ulcers. Now, this amount is increased in cases of hypoglycemia, insulin, and glucose analogs that can be injected into animals or humans or animals that are having hypoglycemia. Also, insulin increases the amount of gastric acid produced. The second phase, which is the gastric phase, controls the majority of the gastric acid secretion. 60% of the amount of gastric acid produced is under the control of a gastric phase, none affected by vagotomy, meaning that it is controlled locally. The cells produces gastric acid locally without the effect of the vagus. So the G cells produce the majority of gastric acid in the stomach without any influence from the vagus. And again, this also can increase by alcohol in case of humans, of course, calcium and caffeine. All of this increase the amount of gastric acid produced. The third phase is the intestinal phase, and that accounts for about 10%, and it's non-gastrin related. So it's basically amino acids that can stimulate the production of gastric acid. This is about 10% of the amount of gastric acid produced is controlled or regulated under these control mechanisms from the intestines, from digested amino acids, basically byproducts of protein digestion. And again, in the intestine. So this is an intestinal phase. So we have three phases that control gastric acid secretion. We have a cephalic phase, we have a gastric phase, and we have an intestinal phase. The majority of gastric acid secretion are produced under stomach control, not affected by the vagus. Now we come to diseases that are related to gastric acid increase in the stomach, and that is gastric ulcers or duodenal ulcers. Gastric and duodenal ulcers. We remember that gastric ulcers inhibit gastric emptying, whereas the duodenal ulcer enhances the gastric emptying. We talked about gastrinoma and the Zollinger and Allison syndrome, the non-pancreatic cell cancers. Helicobacter pylori is a bacteria that affects both humans and animals, and it can also cause gastric ulcers. This is manifested by the ammonia production that this bacteria is able to do. The use of non-steroidal anti-inflammatory drugs also increases the potential of causing gastric ulcers. All of these factors can increase gastric acid secretion, which as a result cause gastric and/or duodenal ulcers. And the way to treat them is through blocking the histamine 2 receptor, maybe blocking the gastrin receptor, which is the CCK2 receptor, or antrectomy, cutting the antrum, or selective branch vagotomy. All of these, we've talked about them previously as treatment for gastric ulcers. You've seen these pictures before. On the left-hand side picture, you have a normal horse stomach, glandular and non-glandular parts separated by the margo plicatus, the dark pink edge that you can see in the middle of the picture, versus on the right-hand side picture, you have a stomach with multiple ulcerative lesions. These are pictures, endoscopic views from pictures taken from humans with perforating ulcers in the duodenum in the left-hand side picture versus a gastric ulcer in the right-hand picture. Both of these were caused by Helicobacter pylori. So this is the extent of hydrochloric acid and the discussion about this acid. The next product of gastric secretions is the digestive enzyme pepsinogen. Pepsin is the active form of pepsinogen. So in the stomach, first pepsinogen is secreted. Once it reacts with the hydrochloric acid at a pH of about 2.3 or so, pepsinogen becomes active, and at that point we call it pepsin. Pepsin is the enzyme responsible for protein digestion. It attacks the interior bonds in the proteins. We will talk about that when we talk about digestion. Pepsinogen is not responsible for digestion of proteins. Pepsin, the active form of pepsinogen, is responsible for digestion of protein, and it is stimulated by the vagus nerve and also by secretin. Pepsinogen is secreted in two groups, in two forms. Group 1 or pepsinogen 1, and that is secreted in the stomach, whereas pepsinogen 2 or group 2 is secreted from the duodenum. So group 1 is secreted from the stomach, and group 2 is secreted from the duodenum. It is worth mentioning here that there is a radioimmunoassay that can be used as a diagnostic test for gastric and or duodenal ulcers by taking a blood sample from the patient and measuring the levels of group 1 and group 2 pepsinogens in the blood. And based on the results, without doing endoscopy, without doing any other invasive procedure to diagnose the case, you can give a confirmed diagnosis based on the pepsinogen levels in the blood. Just like the gastrin levels in the blood in the diagnosis of gastrinoma. We have talked about that during the lecture on gastrin, the gastrointestinal hormones, the 5 gastrointestinal hormones, CCK, gastrin, secretin, GIP, and motilin. And these are the areas where the two forms or the two groups of pepsinogen are being secreted in the stomach. The upper one, which is the black lining, is the area where group 1 is secreted, whereas the lower one, the antrum, the pyloric area, is the one responsible for producing group 2 of pepsinogens. The third component of gastric secretions is mucus. So we've talked about gastric acid as the first component of gastric secretions. We talked about pepsinogen as the second component of gastric secretions, and now we are talking about the third component of gastric secretions, which is the mucus. Gastric mucus is secreted in the stomach in two forms, and I alluded to this earlier. One is soluble and the other one is insoluble. The soluble one is involved in the digestion process, in the lubrication of food, and it is vagally stimulated. So when we cut the vagus, we reduce the amount of soluble mucus production. However, there is another type of mucus which is a very important type, and that is the insoluble mucus. This insoluble mucus basically lines the stomach mucosa, covers the stomach mucosa to make it very difficult for any physical or chemical attack to injure the gastric mucosa, meaning it prevents formation of gastric ulcers. Of course, when you have a case of gastric ulcer, that means that the injury had already broke this barrier. This is a very, very important thing to remember. This picture shows where the location of the two types of mucus in the stomach are produced. you have the parietal glands that produce the soluble mucus from the mucous neck cells, and you have the surface mucus cells which produce the insoluble mucus. This insoluble mucus forms a layer. It's shown by the block drawn on the top of the gastric pit to protect the gastric mucosa from any harmful effect. When I say harmful effect, I mean chemical or mechanical or any other harmful effect. This is very important to remember. So we have two types of mucus, soluble and insoluble. The one that protects against ulcers is the insoluble. The soluble one is related to lubrication and digestion, and that's vagally mediated. Okay. Now we will talk about the fourth and the last gastric secretion, the intrinsic factor. The intrinsic factor that binds, as I mentioned earlier, to vitamin B12. So if the species does not have intrinsic factor, then you have to provide that particular species with vitamin B12. If, on the other hand, the species or the person have this intrinsic factor, then there's no need to provide B12 because vitamin B12 will be bind to this intrinsic factor for the body to utilize it. Of course, this intrinsic factor can be absent in cases of pernicious anemia patients. When you have this case, you will not have the intrinsic factor. Therefore, you have to provide, as I mentioned earlier, these patients with vitamin B12. That's very, very, very important. The intrinsic factor is secreted by the parietal cells. The intrinsic factor is secreted by the parietal cells. Now we finished the gastric secretions, 4 of them. We've talked about the hydrochloric acid, we've talked about the pepsinogen, we've talked about the mucus, both soluble and insoluble, and we've talked about the intrinsic factor. 4 types of gastric secretions. Now we move to the last part of gastrointestinal secretions, or the one before last, which is the pancreatic secretions. The pancreatic secretions are the 4th portion of the gastrointestinal secretions. After we talked about the epithelial cells, secretions coming from epithelial cells, secretions coming from salivary glands, secretions coming from the stomach or the gastric mucosa, and now 4th is secretion from pancreatic origin. Let's look at the anatomy of the pancreas first. This picture shows a drawing of the pancreas in the center of the picture and its relation to the upper duodenum on the left-hand side of the picture. Now, the pancreas has multiple cellular origins. First, you have pancreatic islands. These islands or islets secrete endocrine secretions, endocrine secretions, such as insulin, for example. Insulin, glucagon, these are endocrine secretions from the pancreas. In addition to that, you have acinar cells. Acinar cells. The acinar cells secrete digestive enzymes. Digestive enzymes. Now, lipase, amylase, etc. Finally, you have ductal cells, cells of the duct, cells in the duct. These are important for secreting ions like the bicarb and the sodium chloride, etc. So you have three types of secretory organs or cells in the pancreas. One is the pancreatic islands, and these are the islands of Langerhans. They have alpha and beta cells and exocrine acinides, etc. And we have the acinar cells, which secrete digestive enzymes. I mentioned lipase, amylase, trypsinogen, etc. And then we have the ductal cells. So islands, acinar cells, ductal cells. Let's see what do they do. The islands of Langerhans secrete insulin and glucagon. The ductal cells secrete the ions, bicarb and sodium chloride. And the acinar cells secrete the digestive enzymes, lipase and amylase and trypsinogen. We will divide these secretions into two parts: endocrine secretions and exocrine secretions. These are the two divisions of the secretions coming from the pancreas. Endocrine secretions, which form about 4% of the total secretions of the pancreas. We mentioned two hormones, two endocrine hormones, insulin and glucagon. The other portion of the secretions coming from the pancreas is exocrine, okay? The endocrine, basically, the secretion arrives directly to the blood stream and then is distributed to the rest of the body, endocrine. Whereas the exocrine, no, it goes to the upper duodenum, and they can be divided into two parts: ions, which makes another 6% of the total secretions, which means bicarbonate and sodium chloride, and enzymatic secretions, amylase, lipase, and that is 90% of the total secretions in the pancreas. This is very important to remember. So the majority of pancreatic secretions is coming from the exocrine part, mainly the enzymes. So most of your enzymes that digest the food comes from the pancreas. That's why the pancreas is very important in digestion. The other component, or the second important component of pancreatic secretion is ions, 6%. And then the last one is 4%, which is the hormones, insulin and glucagon. This is another picture that illustrates basically the three different types of cells. you have the endocrine secretions coming from the islands of Langerhans, small circles, small dots. Then comes the acinar cells that secrete digestive enzymes, amylases and lipases, and then the ductal cells which secrete bicarb and sodium chloride. It's worth mentioning how does the endocrine system here work in glucose regulation. This cartoon explains the role of the pancreas in regulating blood glucose. So, for example, you have the pancreas on the right-hand side of the picture, and you have the liver on the left-hand side of the picture. And on top, you have an increase in blood sugar, whereas in the bottom, you have lowers blood sugar. So there are two mechanisms. The pancreas plays a role in two regulatory mechanisms. One increases the amount of blood sugars, and the other decreases blood sugars depending on what we need. So if I or the animal or anybody is having high blood sugar, this blood sugar triggers the release of insulin. This high blood sugar triggers the release of insulin from the pancreas. Insulin reaches the liver. It converts glucose to glucagon to store it, because we do not need sugar at this point. And the end result will be lowering blood sugars. So if I have high blood sugars, what happens is the pancreas releases insulin, and this insulin goes to the liver and converts glucose there to glycogen to store it. It stores it. It keeps it in the liver. It does not send it to the blood. Okay? And that at the end result, it will lower the blood sugar levels. On the other hand, if you have low blood sugar, what happens is the pancreas senses this low blood sugar and releases a glucagon at that point. Glucagon goes again to the liver and converts glycogen to glucose. Once you convert glycogen to glucose, the glucose levels in the blood increases. So when you have low blood sugar, the pancreas releases glucagon, which converts glycogen to glucose, so it raises your blood sugar. However, when you have high blood sugar, the pancreas senses that and releases insulin, which basically converts glucose into glycogen and store it in the liver, because you don't need it. And that's why you will have lower in blood sugars. That's a very important thing that we need to understand and remember. Now, the exocrine secretions of the pancreas consists of two types of secretions. The exocrine secretions in the pancreas consists of two types of secretions. One is ion secretions, and I mentioned the bicarb and the sodium chloride, or salt basically. Or, and this comes from the ductal cells, or the enzymes, digestive enzymes, lipase, amylase, trypsinogen, and they come from the acinar cells. So there are two exocrine secretions that the pancreas produce. One is ions coming from the ductal cells, and they consist mainly of bicarbs and salt. And this depending on the rate of secretion, which is dependent on how active the digestion process is going. If digestion is going pretty actively, that means bicarb will be secreted in very large amounts. On the other hand, if there's no digestion going on, then salt will be secreted at that point. This again is called the two-component theory. The two-component theory. We have heard this terminology before when we talked about the secretions that's coming from the stomach, the two-component theory. Now, how is this exocrine secretion is taking place? Just like the slide that I showed you earlier with the acid, here we're going to see how it's going with the salt and the bicarbs. This is a graph showing what type of ions are present in the pancreatic juice during no food, which is 0, more food, which is 10 and 20, 30 and 40, all the way to the fullness of that juice. Sodium ion is always high, whether there's food, whether there's digestion or not, you have the sodium ion always high. Potassium ion is always low, just like what we've talked about in the stomach. Potassium is always low. Now, when there is no digestion going on, you have low bicarb and high chloride. Low bicarb and high chloride. When the digestion is starting, these two ions start to change. So the bicarb starts to increase and the chloride starts to decrease. At the highest amount, which is 40 microliter per minute, you have high bicarbs and you have low chloride. So in the low digestion rate, you have sodium that's always high and chloride high, sodium chloride. In the high digestion rate, you will have sodium high and bicarb. So you have sodium bicarbonate as the dominant ion in this case. The second exocrine secretion in the pancreas is the enzymatic secretions that are coming from the acinar cells, And These enzymes form 90% of the total pancreatic secretions, both endocrine and exocrine. The enzymes, which is an exocrine type secretion from the pancreas, is basically forming the majority of pancreatic secretions. They are extremely important for digestion as well as for absorption. And so, what are these enzymes? The enzymes are secreted in active form and inactive form. So you have two types of enzymatic secretions in the pancreas. Ones that are secreted actively, they are active when the pancreas secrete them. They are ready to work, and these are lipase and amylase. However, there is another group of pancreatic enzymes that the pancreas secrete them inactive. They are inactive. They need activation to start working. And this group is trypsinogen. And the trypsinogen is basically activated by another enzyme in the intestine. It's called enterokinase. Once enterokinase finds trypsinogen in the lumen of the gut, it activates it, and that's when trypsinogen starts to be active and starts to be digested. And so there's a very important mechanism that, or a number of mechanisms that prevent the enzymes from, or those enzymes at least, the trypsinogens, from actually eating up or digesting the pancreas itself. Because a question will come, okay, well, why, if the pancreas is secreting all of these enzymes, then why these enzymes does not eat the pancreas itself? Well, it's pretty simple. First of all, these enzymes are synthesized inactive. So they're inactive until they reach the lumen of the intestine. And when they reach it, they will find enterokinases, and that's when they convert into the active form. So this is number one. Number two is there are lots of trypsin inhibitors that they inhibit them when they are active. So there's a regulatory steps. If you need them, they are active. If you don't need them, then there are trypsin inhibitors that will basically stop them from working. They are membrane bound. So if you find them in the lumen, they're going to be active, but in their state, they are always bound to a membrane. If they are bound to the membrane, they're inactive. They cannot work unless they leave that membrane. Once they leave the membrane and they go to the lumen, they find the enterokinase. That's when they become active. And also they eat up themselves by trypsin, autodigestion. So there's an autodigestion step that takes them also from eating up the pancreas. So there are four mechanisms, very important mechanisms that will help in basically preventing the enzymes from eating up the pancreas. They're synthesized inactive. There are trypsin inhibitors. They are membrane bound, and there's an autodigestion by trypsin. So now we come to the regulation of pancreatic secretions. What is the mechanisms, or what are the mechanisms that regulate pancreatic secretions? Well, exactly like the stomach, you have a cephalic phase and you have a gastric phase and you have an intestinal phase for gastric acid secretions. Also for pancreatic secretions, you have a cephalic phase, you have a gastric phase, and you have an intestinal phase. And we'll talk about each one of them separately so we can understand it better. First of all is the cephalic phase. 20% of pancreatic secretions, 20% of pancreatic secretions is controlled by the central nervous system, mainly through the vagus nerve. Again, if you cut the vagus, that means you've lost approximately 20% of the pancreatic secretions. They have very low volume, but they are highly concentrated. So the enzymes, the volume of the secretion is pretty low, but they are highly concentrated in enzymes, both exocrine and endocrine enzymes. This is the cephalic phase for pancreatic secretions. The second phase is the gastric secretion. It accounts for about 5 to 10% of the intestinal of the pancreatic secretion, I'm sorry. So 5 to 10% of the pancreatic secretions are basically controlled by a gastric phase, which is the presence of food in the stomach, and again it's vagally mediated. Again, so the vagus controls both the cephalic phase and the gastric phase. Now we come to the third phase, which is the intestinal phase. This accounts for the majority of pancreatic secretions. 70% of what the pancreas is able to secrete is controlled by the intestinal phase, and this phase is controlled by gut hormones such as cholecystokinin. Cholecystokinin basically stimulate or inhibits intestinal exocrine secretions. 70% of the amount of pancreatic secretions, especially exocrine, because the exocrine is the majority, 90% of the pancreatic secretions are exocrine, which is lipase, amylase, trypsinogen, is controlled by gut hormones, which is cholecystokinin. This is how the pancreas works. You have endocrine and exocrine secretions. The endocrine are basically insulin and glucagon, which are involved in regulating glucose levels in the blood. And you have the exocrine secretions, which are divided into two parts. One that's ions, and that comes from the ductal cells, and one that are enzymes from the acinar cells, and these are lipase, amylase, and trypsinogen, and they form about 90% of the pancreatic secretions. And the pancreatic secretions are regulated by three phases: cephalic, gastric, and intestinal. The cephalic and the gastric are basically vagally mediated. The intestinal one is hormonally controlled, which is controlled by CCK. Okay, and this basically controls the majority of the exocrine pancreatic secretions, 75% of these secretions. Now, let's look at some of the clinical considerations for these for the pancreas. What can happen in the pancreas? Chronic pancreatitis. Chronic pancreatitis, very important disease, very devastating both in humans and also in animals. Tumors, cystic fibrosis, all of these affect the pancreas. All of these affect the pancreas. And one of the most important points for clinicians to remember is that only when you have almost total pancreatic damage, which is about 80% damage, that's when you start seeing steatorrhea or greasy stool, greasy feces. These are very, very, very important. Another important point that I want to stress is that When we have pancreatic tumors, we have decrease of trypsinogen and chymotrypsin, trypsin and lipases, but amylase is not affected. Amylase is not affected. This is important. So trypsin, lipase, chymotrypsin, etc. are all decreased in cases of pancreatic tumors. Amylase is not. This is extremely important from a diagnostic standpoint. Also, in cases of cystic fibrosis, we have very low chloride. We have to remember all of these points. If we have chronic pancreatitis, chronic inflammation of the pancreas, there are active proteases. The proteases in the pancreas are active. So trypsin is active. Remember that one of the mechanisms that prevents eating of the pancreas by its own enzymatic secretions is that they are secreted inactive. They are membrane bound. And we've talked about the 4 different, there's trypsin inhibitors, etc. In this case, when you have chronic pancreatitis, you have active proteases, so they start eating up the pancreas. They're eating their own tissue. And for that, you will have low bicarbonates. You will have low bicarbonates, of course, because the pancreas is not able to produce from the acinar cells. Okay, you have obstructions, and you have also increased trypsin. You have trypsin, and again, trypsin that's active, that eats up the pancreas itself. That's why pancreatitis is a very, very, very devastating disease, because once these guys are active, they start eating up the tissue, their own tissue. One of the tests that is done is secretin and CCK tests. The tests basically fail to increase bicarbonate secretion from the pancreas. If you give CCK or secretin to these animals or humans, you will have no good response. The pancreas is unable to produce bicarbs. This is a very good indication that the pancreas has a pretty serious illness. That's very important to remember. Very important to remember. And again, please remember that you do not see steatorrhea or greasy stool all the time with pancreatitis. It's only when you have major damage, over 80% of the pancreas is damaged, that's when you start seeing fat in the feces, because it's not able to digest, because the pancreas, which produces lipase and amylase, mainly lipase for the fat digestion, is not able to produce the fat. So the fat goes out without digestion. And that's why you see greasy stool. Also, we know that secretin and CCK increases bicarbonate secretion, sodium bicarb from the pancreas. So if the pancreas is having a problem, if you give secretin and CCK, the pancreas is not going to be responsive. It's not going to release or secrete bicarb. And that's a very good lab test indicator, if you will, to show that the pancreas is not functioning. The most important thing also is about tumors. All of the enzymes are decreased except amylase. Please remember that. In case of pancreatic tumors, all of them are decreased except amylase. Amylase is not decreased. This is picture that you have seen before, and it shows the pancreas and its relation to the duodenum as well as to the gallbladder. See that they share the same common opening. Well, at least in certain species. Some of the species they have two different openings for the pancreatic duct and for the gallbladder. But in this case, the humans they share the exact same opening, which is guarded by the ampulla of Vater. And now this is where CCK works on the pancreas to increase exocrine pancreatic secretion. Also, CCK contracts the gallbladder to release gall bile, so it can digest fat. That's why when you have a problem with the pancreas, bicarbs is not being able to produce, and then the gallbladder is not able to get the bile into uh, the the intestine, and that is why you will have feces in the stool, especially the lipase. The lipase is the most important part in this case, and that's why CCK and secretin are used basically to as diagnostic tests in cases of pancreatitis. Okay, so and up until this point, we finished the secretions of the pancreas. Next, I will be talking about the secretions coming from the gallbladder, and which are the biles and the bile acids and things like that. And we'll finish the secretion lectures next time.